Live. So, good morning, everyone, from the International Society for Coronary Artery Surgery, ISCAS, part of the International Coronary Congress. I'm Gianluca Torregrossa from Philadelphia, and I'm here today for a new event or a new live talk. Live talks are events that the International Society of Coronary Artery Surgery is trying to organize in order to promote the culture of coronary artery surgery around the world in a very friendly and informal discussion in front of a cup of coffee on a Saturday morning, discussing with experts the major topics related to coronary artery surgery, with a direct feedback to all of our friends and colleagues, cardiac surgeons and cardiologists around the world, in order to provide with real data and real information that can be learned on a weekend and apply on our patients on Monday morning. These events are part of the nature of the International Society of Coronary Artery Surgery, that is to promote education around coronary artery bypass grafting and coronary artery disease. Today, I'm here as a first talk of 2023, and I'm together with a relevant group of colleagues and mentors. I'm here with Dr. David Taggart from Oxford and Dr. John Pascas from Mount Sinai, New York, that are the heart and the brain of ISCAS and International Coronary Congress. I'm also here with Dr. Steve Goldman from University of Arizona College of Medicine, Tucson, first author of the VA recent published data of the long-term saphenous vein versus radial artery. I'm here with Dr. James Tatoulis from University of Melbourne, and a big kudo to Dr. Tatoulis, who is joining us from Australia, where it's basically 1 o'clock in the morning or midnight. I'm here with Dr. Frame Stephen from Sunnybrook, Toronto, who apparently is in Florida right now, so a better time and definitely a better weather for him than Toronto. I want to remind all of us that this International Society of Coronary Artery Surgery is trying to organize these live events in a form of agenda to be very structured. If you have followed us in the last year, we had around 7 of these live talks. It takes a lot of time to get ready, to have all of the guests and everybody invited. But definitely we are for this year trying to have a very schedule and tight and respect this tight schedule. You'll see for now only up to August, but we have fill up all of the most important topics that we will discuss for the entire 2023, with the aim to give you every month one appointment to follow for the first weekend of the month. I'm seeing a lot of you saying hello, everyone, and good morning, and this is great. I remember we are streaming live from YouTube, Twitter, and LinkedIn. You can follow us from the platform that you like the most, and you can use the comment section to intervene, to ask us direct questions. The beauty of these live talks is that it's not a formal Zoom where you just listen to the presenters, but instead here you have the opportunity to be part of the audience, to be part of the discussion. We always, at the end of the talk, will highlight the most important question that we will have from all of you. So please keep continuing telling us where are you streaming from. I see someone streaming from Pakistan and saying hi from Pakistan, and this is all great. So we should keep having this feedback from you guys. Tell us question, tell us where are you from, And let's keep continuing this connection, this community of physicians interested in learning about coronary artery surgery. I want immediately to give the floor and the talk to Dr. Steve Goldman, and I want to thank him personally to accepting our invitation. I know it's pretty early too in Arizona. I hope he has had already 1 or 2 cups of coffee, and he's going to give us his presentation about the study, the VA study, the long-term outcomes of the VA study, radial artery versus saphenous vein. Dr. Goldman, the floor is yours.
Thank you for inviting me. I appreciate it. Everybody should understand I'm a cardiologist, so I'm a stranger to the surgical group. So I appreciate the invitation. I've worked with cardiac surgeons for a long time looking at graft patency after coronary bypass surgery. And just to remind everybody, we published our radial artery study, first radial artery study in 2011 in JAMA. And if you look at the authors here, I want to note that you should see that Steve Freems is an author on this paper. And that's an example of the collaboration we've had with surgeons all along for this work. So just briefly, when we published this in 2011, we randomized 733 patients to saphenous vein or to left internal mammary to the LAD, and then the remaining best recipient vessel got randomized to either a radial artery or a saphenous vein graft. All our studies up to this point were graft patency data. So the graft patency at 1 year was 89% both in the radial artery and the saphenous vein graft group. And there were no differences in any of the secondary endpoints. So if I could go to the next slide, which is our more recent publication, and just recently in 2022 in Circulation, where we looked at the long-term mortality in our patients. This is a 17+ year follow-up, and it's a Kaplan-Meier curve, and as you can see, that there's no difference in survival all the way out to 17.95 years. And note that the patients that participated in the study are outlined on the x-axis. And when you look at this, as we do any long-term study with patients undergoing CABG surgery, it's a high-risk group in terms of mortality. So the number of patients, obviously after 17 years, gets fewer and fewer at the terminal endpoints. That's just the fact of life in these studies. I would also add that a recommendation to other people doing this kind of work is when you plan these studies, you ought to plan in the initial consent form to get the patients to agree to be followed, at least to be contacted for the rest of their lives. We did this follow-up work through the VA. They have a death index that the health economist helped us do all this follow-up work. But when you plan these studies, it would make life a lot easier if you had the consent form agreed by the patients to be contacted in long-term follow-up. So the summary of the 17-year follow-up is there's no difference in mortality at 17+ years. The only other issue, if I could, and this is the secondary endpoints. We had prospective data on these endpoints, and there's no difference in any of these: age, smoking, diabetes, hypertension, or triglycerides. Okay, the next slide, if you would, please. When we look at the use of the radial artery for a conduit, there was this article published in 2018 showing less than 10% of the surgeons in the United States, at least, are using the radial artery as a conduit. When I got asked to do this talk, I found another article, at the next slide, please, which is reference at work from that was just published in 2021. And there's a quote in the article from the STS database that less than 5% of CABG patients received the radial artery as a second arterial conduit. Interestingly enough, that's not cited, so I couldn't actually find the data for that. And just as a side, as a cardiologist, trying to get access to the STS database is very difficult. Years ago, we had access to it, but that was because of the relationship with the surgeons that we've had all along. So That's the end of my presentation. Again, thank you for inviting me, and I'm glad to participate in this panel.
Thank you so much, Dr. Goldman. This is has been a topic of discussion in social media and in our society. And thank you so much for being able to present all of this data here today with us. I will ask Dr. James Tatulis from the University of Melbourne, that has been another incredible leader in the world of coronary artery surgery, to present his own data of the recent presented data of the American Heart Association of the 15 years outcomes of another important randomized trial, that is RAPCO, Radial Artery Patency and Clinical Outcome Study.
Thank you very much, Gianluca. If we could go down the third slide. Sorry, I do apologize. So this study we carried out from 1996 to 2005. So it was really in the first year after radial arteries became sort of routine use for us. So it was done a long time ago. And concentrating on the second part, we randomized for the second graft radial artery or saphenous vein for those patients over 70, essentially. So if we could go down a few more slides. Keep going. These are the other ones. Keep going. Keep going. Keep going. These are the reader parts. So this trial had two. Thank you. So this trial had two components. That one component had radial artery versus FRETA in younger patients, but radial artery versus saphenous vein in those over 70. And it was truly randomized with 113 radials and 112 saphenous veins to the second most important artery. So next one, thank you. Next slide. We were able to do a 10-year angiographic follow-up, and essentially each patient had an angiogram. So 10% had an angiogram 1 year, 10% at 2 years, etc. So we tried to angiogram all of them by 10 years, and we were successful in 80% of these patients in having a protocol angiogram, and we only lost one patient to follow up. So the 10-year angiographic data, which I don't have here, showed a slight benefit for the radial artery. The 10-year patency was 91% for the radial artery and 82% for the saphenous vein graft. So now we come to the actual clinical results, so 15-year follow-up clinical results, and you can sort of see the characteristics. The average age was 73, 50% had diabetes, and they were very well matched. Next slide. And these are essentially the results. When we combined mortality, myocardial infarction, revascularization, there was a benefit for the radial artery at 15 years at a p-value of 0.04. Excuse me. Next slide, thank you. The benefit was both absolute in 13% and relative in almost 30% of cases. So there was a clear benefit for that. Next slide, thank you. And in particular, the mortality benefit, again, was 11% for the radial and a relative benefit of 26% for the radial artery. So, and when we looked at patients who were 73 years or older, so that was the upper half of the cohort, there was a benefit, as well as a benefit, obviously, from 70 to 73. There was a benefit for males and females, and there was a benefit for patients with diabetes as well. So essentially, we were able to show that at 15 years, there was a clinical benefit for the radial artery over saphenous vein. And this really shows that our thesis had been accurate all along. I would just make in this the final conclusions that basically over 15 years we're able to show that those patients that had a radial artery benefited by comparison to having a Frita or saphenous vein in particular, and that we would recommend using a radial artery graft. And we've probably done about 25,000 cases with radial artery grafts since 1995 based on these experiences. Just two comments I'd have. Thank you very much. Just to put in place, the saphenous veins we angiogrammed were the best bits of saphenous vein. They were the saphenous vein from the leg, no valves and very few branches. And also, a lot of these studies were done from 95 to 2000, the first 5 years of radial artery use, where we did not understand fully the nature of competitive flow and its effects on the radial. Thank you.
Fantastic. Thank you so much, Dr. Tatulis. And I'll leave Dr. John Pascas. I'm trying to unmute your and Dr. David Taggart. Here we are. Please. Dr. John Pascas.
Thank you. Well, first, I want to thank Dr. Goldman, a cardiologist who's had an illustrious career, including numerous clinical trials related to coronary surgery and conduit patency and outcomes for coronary bypass patients, and we're grateful for his participation. Of course, Jim Tatulis has been a global leader in arteriovascularization for more than 1 decade, and we're delighted to have his presentation as well. When I look at randomized trials that have different outcomes, I am reminded of the bias that is implicit in randomized trials. And that bias, of course, is at the point of recruitment, of entry of patients, selection of patients for enrollment in the trial. And so I'm curious to know, in Dr. Tatulis' RAPCO 15-year follow-up trial, we had saphenous vein graft compared to radial artery graft in patients over age 70. In fact, the mean age was 73. I would venture to guess that the average age of patients enrolled in the VA trial was substantially younger. But I wonder if the two presenters could comment briefly on the characteristics of those patients and how that might have contributed to the different outcomes that we see. And then I guess another aspect of randomized trials also in cardiac surgery, of course, relates to how the surgery is performed. Were all these operations done on bypass, off bypass? Were particular arteries chosen for the radial artery conduit? How were surgeons directed to use that radial artery versus a vein graft? Was inflow from internal mammary arteries or from the aorta? There are many technical factors that could play a role. And I would guess, without clear evidence or data, that the US VA Medical Center tended to perform standard on-pump operations with a cross clamp or 2 clamps with what we call top ends, inflow from the aorta. And some of the Australian sites, which have a good deal more facility with radial artery and all arterial grafting, might have used other configurations. And finally, again, the experience of the surgical teams, I think, plays an important role. Outcomes have to do with expertise and experience in the operating room for surgical teams. And I'm going to venture to guess that the Australian group or groups, which have really a very long track record of sophisticated coronary surgery, and particularly arterial grafting, may have had more experience at the time of beginning to participate in these trials with arterial grafting than the VA teams. But again, that would require some look at the data. So thank you both presenters for joining us today.
You're welcome. Dr. Goldman.
So let me just comment on the VA cooperative study. So you're correct that the vast majority were done on pump. The average age was 61 in the radial artery, I think, and 62 in the saphenous vein graft group. So we're younger. The issue about experience and the quality of the surgeons has always come up in any VA cooperative study. And I would advocate that I don't think that's, I don't think it's fair from the VA perspective. All our surgeons had university appointments at the VA. They were all faculty at the university. And for example, in our radial artery study we published in 2011, the mortality was acceptable in the STS standard databases. So the quality of the surgeon, at least defined by endpoints and operative mortality, was no different than what's done anywhere in the United States. So I guess this issue of the experience of the surgeon has come up a lot in the criticism of work in the United States. But I would argue that if that's a major concern, then why is the use of radial artery as a conduit so low in the STS databases in the United States?
Dr. Tatulis.
Thank you. I don't know if it's easy to get the slide up, but it was one of the baseline characteristics about halfway through. But as you heard, you have to go. It's back. Yes, that's the one. So you can sort of see that the mean age was 73, and over half were diabetic. And Dr. Puskas asked about the arteries they went to. And about 65% went to the circumflex or the ramus, and about 30% went to the right coronary artery. So that would be more the posterior descending. So essentially, it's what we would do today. So that's probably not much difference. But as I remarked, we were doing these cases before we realized the full implications of competitive flow. It took us, we were a bit slow, so it took us about 5 years to realize it. So that does color the results a little bit. And in terms of interpreting why the results are a little bit different, well, firstly, a 15-year follow-up is required to really see it. But secondly, I would hazard a guess that if the mean age of the VA group was 60 or 61, those patients are more likely to live well and longer in relation to their surgery as opposed to 73-year-olds. So I think there's probably going to be the influence of other comorbidities. So in general terms, I think younger patients do well no matter what you throw at them. So I think that may be a part of an explanation. But these are the results we found. We had 5 surgeons that were involved, and all these cases were done on pump, single cross-clamp technique. There was 1 mortality in the 225 patients, and essentially we used aortocoronary grafts, and all of these were single one-to-one grafts, so they could be compared.
Interesting. Dr. David Taggart.
Thank you. Let me first congratulate both our speakers on actually conducting these trials, because trying to do any surgical trial has major logistic problems compared to pharmacological trials. So congratulations, and thank you for your beautiful presentations. I wonder how much of what we're seeing when we have 2 conflicting trials in terms of results are to do with patient selection. We as cardiac surgeons have criticized many of the trials of PCI versus CABG because the entry criteria very much favored the use of PCI. Now, what is surprising in the results today is if one had to think about what you would have expected the VA trial with the younger patients to have shown the benefit of a radial artery over the longer term. But in Dr. Tatoulis' trial, they did show that, but in much older patients. What I noticed about the RAPCO trial was that almost half of patients had been excluded at entry. And I would ask myself in today's practice, how many patients would I not be prepared to randomize to a radial artery versus a saphenous vein in that cohort? So it makes me wonder why there were so many patients excluded from the trial. For Dr. Goldman's trial, we don't know because it doesn't tell us what proportion, a relatively small cohort of patients, around 700 patients, what had been the potentially eligible population versus who was entered into the trials. My final comment would be, I didn't quite follow why in the RAPCO trial, radial artery did so much better. The patients were very well matched, and where the real benefit of the trial was in mortality. And if that is real, it is extremely important. But if you then look at the incidence in both groups of myocardial infarction and repeat revascularization, they were similar. And I would have anticipated in a group who had better survival with a radial artery, that would have been reflected in data regarding myocardial infarction and repeat revascularization. So I don't know really what is happening here. Both studies, as I've already intimated, both authors should be congratulated on their studies because they're very difficult to do, but they both ended up with relatively small cohorts of patients with large numbers of exclusions, at least in the RAPCO trial. And therefore, I wonder if that might in some way explain the discrepant results. But again, congratulations to both groups for their superb work.
Oh, thank you, Dr. Taggart. I'll start. I think we started off screening about 900 odd patients, and about 350 were randomized to the RETA arm, and 225 randomized to the saphenous vein arm of the trial. So you're right, about 40% of the patients were excluded. Two main reasons they were excluded. One was that they had to agree to have a protocol angiogram, and some of the patients that we initially thought were suitable refused or were not confident they would have a follow-up protocol angiogram. And the second lot was people that had saphenous vein conduit problems, so that we were not confident, excuse me, that we'd be able to use the saphenous veins that we wanted to. So those were the sort of two main reasons for the exclusions. All these operations were carried out at teaching hospitals, although specifically for this trial, the attending surgeons did the actual surgery for those particular grafts. And the results, although they're sort of striking. It took 15 years. I mean, so yes. You could say the first 10 years, there really wasn't a huge difference. It really took 15 years. And that's not dissimilar to the bilateral mammaries taking 10 years to show a difference in observational trials, at least. So it does take a long time. I think they're the main comments.
And I would just add that I don't have the data on our denominators. I don't know how many patients were screened. The decision to enter the patient into the trial was done by the attending surgeon. So the surgeon saw the patient with the data coordinator and evaluated the patient, presented the study design to the patient, and the surgeons made the individual decision on whether or not the patient was acceptable, and then the patient had to agree to the trial.
I'd like to ask both Dr. Goldman and Dr. Tatoulis, what is the baseline use of radial artery outside that trial in your institutions during the time of enrollment? In other words, were patients being randomized to have what would be considered a routine procedure, a radial artery graft, or were they being randomized to have something that was unusual in that institution and for those surgical teams?
Well, if Dr. Goldman?
So I'll go first. We started this trial when the radial artery enthusiasm initially for the radial artery was, I would say, high. That's what got us started in the trial. So we were doing radial arteries as the surgeons were doing radial arteries even when we started the trial. So it wasn't something new for the surgeons. Surgeons all had experience in it. Having said that, our institutions over the years, I don't think have adopted the radial artery any more than is in the STS database. So I'd say my survey, and it's not a large prospective survey, but I've talked to the surgeons at the institutions that were in the trial, and they do not use the radial artery very often. So 5 or 10% would be what I would expect, maybe even less than that.
The RAPCO trial started in June 1996. We were using the radial artery fairly extensively at that stage. I couldn't say it was every operation, but certainly very liberally used. So we did have a fair bit of experience with it. And as I said, the other slightly unusual thing, we only ever used the saphenous vein from the lower leg. We never used saphenous vein from the thigh. We gave that up in the 80s. So there were sort of two key operative features. Today, we use the radial artery absolutely routinely every case, and in about 28% we use bilaterally, especially when it's not been instrumented.
Gianluca, could we ask Dr. Freems?
Yeah.
Dr. Freems is obviously highly experienced both in clinical trials and clinical practice. And could we ask him, what is his take on the apparently superficially conflicting results of these trials?
Yeah, sure. I've lost David. I think some of what you said was missed. It wasn't picked up in the feed. But thanks for the invitation. These were very valuable meetings. Can everyone hear me?
Yes.
Okay, fine. A comment. One of the things that both of these trialists have done is show very long-term results. And I think for coronary surgery studies, long-term rather than short-term results are very important. And usually when we say long-term, we think of 5 to 10 years, but these studies carried complete follow-up out to 50 years. So both groups should be congratulated for executing a very thorough long-term follow-up. Now, some differences. Yeah, there are differences. The VA study at the time pretty well only recruited men. Now, it may be different now because there are a lot more women involved in the U.S. military, but at the time they basically only included men. And in Australia, they include a small number of women, but they included women. And in the meta-analysis of which several of us have been co-authors that were published in the journal, now the VA study was not included because to be eligible, the study had to have at least 5-year results. And that time, the VA study only had 1-year result. But female was associated with a benefit. In other words, the benefit was greater in women than in men. And that was seen in Jim's study as well. So that's one difference. The other is one's multi-center and one's single center. And regardless of the comments that have been said already, I think it might be said that Melbourne was a center of excellence for arterial grafting. I'm not saying that the VA studies were not centers of excellence for surgery, but I think it's probably fair to say that Melbourne was a center of excellence and probably still is a center of excellence. In any case, they were single center versus multi-center. Another thing that both of the studies are, though, are graft patency studies. And usually you have to be a bit more selective when you're recruiting someone for a graft patency study, as opposed to an all-comer study. They have to be suitable for repeat angiography. Their creatinine can't be that high. Generally, they should be younger, but in Jim's study, they were obviously older. So that distinguishes it from perhaps the ART study, which was not a graft patency study, and distinguishes it from Roma, which is not a graft patency study. And in these cases, the clinical outcomes were not the focus of the trial. That was a secondary endpoint. The primary endpoint was graft patency. I'll make one final comment, and that is there's some uncertainty as to the correlation of graft patency and clinical outcome. In general, we think that clinical outcomes are predicated on graft patency, but there's certainly people can have silent graft occlusion for a lot of reasons. However, in the studies that have shown a benefit clinically with arterial grafting, they've also shown a benefit in patency. And the fact that for whatever reason, I'm not sure what the reason is, that an improvement in patency was not seen in the VA study, there was no benefit long-term in terms of graft, in terms of clinical outcome. So I think I'm not sure of the reasons, but the fact that there was no difference in long-term outcome, I think, is to be expected based on the fact that the patency was similar. So I'll stop there.
I think as we talk about graft patency and alternative conduits, it's important to also think about optimizing the patency of whichever conduit we choose. The manner in which a vein graft is harvested from the leg, prepared for surgery and deployed onto the heart makes a difference in graft patency. And I think it's intuitive and compelling to believe that graft patency, as Dr. Freems pointed out, will track with outcomes and longevity for the patient. So the same applies to radial arteries. A traumatically harvested spastic radial artery will not be a good conduit. An over-distended vein graft, which is heavily manipulated and then exposed to aortic pressure, is likely to develop neointimal hyperplasia and have a limited patency. So whether we choose a vein graft or a radial graft, I think it's absolutely essential that all surgeons harvest every conduit in a way that will optimize its patency.
Let me ask a question, since I'm a cardiologist in a surgical group here. Today, we do most of our cardiac catheterizations with radial artery access. And when we first started this trial, there was a long discussion about Allen's test and all that sort of thing that we don't do anymore. But I raised the issue with our surgical colleagues. What decision did they make if we cath the patient from the radial artery access? So I would ask you guys, how do you handle that today in your everyday practice when the patients get cathed by the radial artery?
Well,
Could I make a stab at that?
I'll jump in. We don't use it.
You don't use it. You, Dr. Taggart, what do you do?
So we published, I think, quite a summative review in Circulation about 2 or 3 years ago, looking at all the evidence in the literature at that time that compared patency of bypass grafts with radial artery out to 6 months to a year. And there was a clear increase in radial artery failure in those radial arteries that had been catheterized within 3 months of use. So our practice is we would not use a radial artery that has been catheterized within 3 months. But we also try to, I think this is another place for mutual cooperation between the cardiologists and the surgeons. Because in our institution, most radial artery catheterizations are done from the right arm and not the left. So what we ask is to please leave the left radial artery. If you have a patient, so we ask the cardiologist, if this is a patient whom they think is potentially a candidate for bypass surgery, could they please try avoid manipulation of the left radial artery?
Very true, and I can highlight even more what Dr. Tagger just said. I think it's very important. I always ask to all of my cardiologist colleague, please be cognitive of the importance of the left radial, particularly for a young patient. If a young patient comes for an elective cath because the CT calcium score was positive, consider the right radial as your only source or radial access to do a diagnostic cath, because that left radial could be very important. I personally, in my practice, use radial artery, even if they've been recently cath. I exclude the portion, of course, that was punctured at the time of the cath, but I tend to use it after a careful inspection. Dr. Pascas, what do you do?
Well, I would echo Dr. Tatulis's last slide, which said, we don't really know the impact of catheterization on the longer-term patency of a radial artery. But and it's not a political statement. I would encourage the cardiologists to go right and the surgeons to go left. That I think will keep us all straight and provide at least one a radial artery graft. I'd like to echo a comment that Dr. Freems made a few minutes ago, describing a paper published in the New England Journal, looked at 6 different prior randomized trials of radial artery versus saphenous vein graft in a patient-level meta-analysis. And that trial, that meta-analysis showed a striking advantage for radial artery over vein graft with the same kind of concordance between avoidance of future MI and prolongation of life. So patency was better with radial artery than vein. Avoiding MI was improved, and that translated into longevity. Now, as Dr. Freems pointed out, at the time that meta-analysis was done, the VA trial did not yet have its longer-term follow-up available. So it was excluded from that particular meta-analysis. It wasn't part of that analysis. So we do have a lot of conflicting data in the literature. And I think we have to acknowledge that these are data that conflict in their messaging, and the trials are all performed by conscientious and skilled trialists, including Dr. Goldman and Dr. Tatulis. So we have to look at, again, optimizing whatever strategy we use. For me, it's an all-arterial default operation. And I think that's okay if that's what you can do. But if you're doing a lima and 3 veins, you ought to do that in the best way possible. And again, if we're going to use veins, let's not beat them up. Let's harvest them atraumatically. Let's not distend them. Absolutely do not store them in a saline solution, but rather in a buffered plasmolyte or other sort of solution. And the same applies to the radial artery. A catheterized radial artery demands inspection, as Dr. Torregrossa commented. We always exclude that part that's been punctured. And frankly, as recently as yesterday, there was only a portion of that previously catheterized left radial that was usable, and we put that as a side limb off the left mammary to reach the mid-marginal. But the rest of that radial artery was not appropriate. It had some scar in the intima, and I think it's important to be aware of that. I'd like to ask the panelists, what are your thoughts about calcified radial arteries? Not infrequently, a patient may have a widely patent radial that has a substantial burden of calcium in the wall of that vessel. A calcified radial may be better than a big varicose vein, but there are moments in time when one is looking at these 2 alternative conduits and trying to figure out which one to use. What are the thoughts of our surgical colleagues?
Dr. Frames, What do you think? What do you do? And you had a comment too. I
Yeah.
saw that.
Yeah. So to answer John's question, well, in addition to a clinical exam, we do get an ultrasound before the patient goes to surgery. So that the ultrasound shows the size of the radial artery. It's a confirmation of the adequacy of ulnar collateral circulation, and also it says what the quality of the radial artery is. And if it's disease, we would prefer not to use it unless there's a problem with conduit. Now, so we would know that usually before the patient goes to the operating room. I wanted to add an additional comment to what Stephen Goldman was saying about using the radial artery after angiography. It's quite clear that radial artery access is safer for the patient than femoral access. But there are situations where the cardiologist has a pretty strong indication the patient has very extensive coronary disease and the patient has varicose veins, or the patient's had their veins stripped. And I think there are situations where the cardiologist can decide in an elective situation anyway that using femoral access is probably better than radial access. So I certainly am on board with the cardiologist using radial access. I understand the data, but there are certainly patients in whom I think it is a mistake when there's no other conduits or there's poor conduit options for the patient. Thanks.
Let me just add something here. Thanks. We have what's called a heart team meeting every week where the cardiologists and the cardiac surgeons discuss cases that are coming up, problem cases, potential cases. So this kind of discussion is what we would propose if our institution used a lot of radial arteries to have at the heart team meeting, because face-to-face meetings between the cardiologists and the cardiac surgeons solve a hell of a lot of problems that otherwise don't get addressed.
Gianluca, if I can add a comment. 10 years ago, when we started using radial arteries, we compared them first to, did you have to do an Allen's test? And we showed that you didn't. So we disbanded that idea. And it was based on the fact that if you think of the tens of thousands of patients in intensive care units who have radial arteries blocked after catheterization necessary for intensive care, none of them ever lose a hand, never. But what we then thought about was this issue of calcification in the radial artery. And intuitively, we thought this is bad. But they were good caliber vessels, and we decided, well, unless it was dense calcification, and the calcification tends to be more distal, we harvested them. And the benefit of a calcified radial artery is it never goes into spasm. You can forget pharmacological medication in them. They will not go into spasm. So unless you think it's a radial artery, and you can discard the last centimeter of it, and there may still be some residual calcification, but we eventually became quite comfortable using those.
I think that's fascinating. I remember years ago when we first started doing all arterial grafting and talking about it and presenting it, a surgeon came up to me at one of the annual meetings and said, gee whiz, I love using the radial, especially the calcified ones, because I know they'll never spasm.
I agree.
And at that time, I looked at him and thought, that's an interesting idea. It's not easier to handle for the anastomosis, but there may well be some rationale to what you say.
Dr. Fatulis.
Just some brief comments. We do use mildly calcified arteries, but the main problem is having a leak-proof anastomosis distally. I think that's the challenge. It's not whether it's calcified or not, and usually the calcification is more distal, and it's on the volar surface of the artery. We also do not use radials that are smaller than 2 millimeters in diameter. So I think that's a very key technical point. And also with instrumented radial arteries, we sometimes do use the proximal third or half if we have conduit shortage. But the other problem is that even if you exclude the bit that's been traumatized, the radial arteries on the instrumented size are never as big as the non-instrumented ones, and they also lack vascular reactivity. So I think physiologically they suffer as well.
Gianluca, may I ask? Sorry.
Please. I want one super brief question. Dr. Tatulis, give us your recipe for your radial artery, meaning do you open your fascia and where do you store your radial while you are getting it ready before you prepare it? What is your solution of storage?
Yeah.
And do you think that the fascia makes a difference?
Well, yeah, we harvest it open with a harmonic scalpel, and we open the fascia, certainly the distal half, sometimes the whole lot, and we inject it with heparinized arterial blood with 1% papaverine within it, and store it in the same solution in papaverine heparinized arterial blood until we use it. And generally, we use it as the first conduit.
Gianluca, can I ask the panel, please, what their view, and especially as we have a cardiologist, Dr. Goldman, what is the surgical and cardiological view of the necessity of long-term pharmacological management of a radial artery? So do you use antispastic medication for 3 months, 6 months, a year, or not at all?
From the cardiologist's perspective, we don't use it at all.
Thank you.
Now,
Dr.
there was
Tatulis.
a paper from England, from Australia, and I think, Jim, you were the first author, or maybe it was your late great colleague, Dr. Buxton, that commented that longer-term calcium channel blocker administration in patients who had radial arteries was associated with a statistically significant improvement in survival. So, I mean, even a difference in how these patients were managed after radial artery grafting could have a significant impact on the benefit of that arterial graft, that radial artery.
Well, that's certainly possible. To go to Dr. Freems's questions before, in the RAPCO study, there were more females, and they showed a greater benefit for the radial artery than males, although both showed benefit. It's in the third last slide, Gianluca, and nearly 60% of the patients were diabetic, so they also benefit from a radial artery. In the third last slide, third last.
Third to last. Okay, 1 second.
Oh, that one, yeah, that one more back. That one, yes. So you can see that females actually benefited more than males, and also patients who had diabetes benefited a lot. And 60% of the patients were diabetic. So that may also be one of the reasons why these results are a little bit different to the Arizona results. And also we have used amlodipine as a calcium channel blocker for at least 6 months, but usually a year, and if we can, even longer. And you're right, there was a meta-analysis which showed that if patients had calcium channel blockers for a year post-surgery, they had a greater survival. Thank you.
Thank you, and thanks everyone. So just a quick firing, Dr. Freems, I want to know your recipe for radial artery. What do you, to the surgeons who are using radial artery, what do you do for your patients? Do you do open or endo in your institution? Where do you store your radial artery before use? Generally, where do you do your proximal? You do it on a saphenous vein hood, or you do it directly on the aorta? And do you open the fascia? Yes or no?
Right.
Thank you.
So yeah. So at our institution, it's generally open, although one of the other University of Toronto institutions, it's usually endo. So that's not the same practice across the university. We typically do not open the fascia unless we find that there's some impairment of flow or bruising and in which case we're trying to determine what the issue is. We usually use a mixture of papaverin and verapamil. When we started doing this, diltiazem was recommended, but diltiazem parenterally was quite expensive where we were, so we used verapamil instead. And it's mixed with blood, and we generally will keep it stored in the same solution, or if it's on pump, we keep it pressurized after it's come out, attached to the de-airing side of the arterial cannula. And it's usually aortic coronary. And it's usually aortic coronary direct to the aorta, unless it's quite small, in which case it's usually to a hood.
Dr. Tutulis, you want to give, you have a comment or a question?
Well, no, well, just to finish up with, yeah, I think the Radial is a great conduit. As I said, we've done over 25,000 cases with it. And I think we just use it exactly like you'd use a saphenous vein graft. And I think it's more versatile, easier to handle, and probably results in better long-term outcomes. And particularly for older patients, allows earlier ambulation. And it's a great conduit for diabetics.
Fantastic. Dr. Goldman, before closing and do some final remarks, I want a question for you. So you are a very prominent cardiologist. You've been involved in this business for quite a long time. Let's say, hypothetically, you need a coronary artery bypass grafting. This is the question I ask to all of my cardiologists. So now you have triple vessel disease. You came out, you had symptoms, positive stress test, the CT calcium score was very elevated, diagnostic cath showed severe coronary artery disease, triple vessel, involvement of the left main, all of the characteristics for a surgical case. Preserve ejection fraction, okay? You choose the best surgeon in the United States. You have access to all of them in your agenda, in your phone probably. And what are the 4 things you tell to your surgeon, or the 5 things you tell the surgeons before going into the operating room? What do you ask him? What type of surgery you want on yourself?
Well, let's assume I don't have to ever address this question.
Absolutely.
Theoretically,
Totally theoretically.
I've worked with surgeons for a long time, obviously. So my approach to this issue is I don't tell surgeons what to do. I tell them, do what you should think you should do the best operation you can on me, and get it done well, get it done quickly, and get me the hell out of here. And that's what I would tell my surgeon.
That's a very good remark, and it's very true. Would you like to use a radial, or you say use whatever you are used to?
I'm telling you, I would choose my surgeon and let he or she make that decision.
Very fair.
Let me ask you guys a question. How about commenting on this debate about the guidelines? You guys haven't mentioned this at all during this session.
Dr. Pascas, we have dedicated an entire live talk last year on guidelines, but Dr. Pascas, go for it. I think this is all yours.
We did indeed have a very robust hour, or a little more than an hour, discussing the guidelines in the last calendar year, Dr. Goldman. But, to me, it's an absurdity to see cardiac surgeons fighting tooth and nail over which is their favorite second conduit. If you go back in the literature, you can see people fighting over whether to use a Lima to the LED or not. When it first was developed in the late 1960s and early 1970s, it was heavily criticized as too technically difficult, inappropriate, inadequate flow, et cetera. And, it took a long time for the left mammary to the LED to become standard and indeed a metric of quality. Now we have another debate and occasionally impassioned discussion of a radial artery versus a right internal thoracic artery as the next best conduit. And now today we revisit whether a vein graft outperforms a radial artery. I think a few important points. In my mind, arteries are designed for arterial pressure and veins are not. So it is somehow biologically intuitive that arterial grafts should outperform vein grafts over the longer term. And, remember that although the first internal mammary artery graft in the United States was done in 1968 by George Green here in New York, it only took until about 1973 for the first paper to be published with pathologic studies of neointimal hyperplasia of vein grafts. And so just shortly after coronary bypass surgery got started, we already knew about neointimal hyperplasia. More recently, we've learned from people like Ki-Bong Kim in Korea that if you handle the vein with great respect, no touch technique, and perhaps especially if you bring it inflow from an internal mammary artery, with the benefit of nitric oxide and other hypothesized good things coming from the mammary, the vein grafts can have extraordinarily long patency. So I think, as you pointed out, Dr. Goldman, it's important to do an operation that the surgeon is comfortable with and to do it very well. And I think an important part of that is careful, really, truly meticulous handling and preservation of the coronary conduits, no matter how they are harvested. For me, it's all arteries. It's double mammary as a default operation with the left radial. That's 90+% of all the coronary surgery we do. But others will get very good results with their own operation if they handle those conduits with great respect.
Okay, we are approaching almost the hour. Actually, we have passed an hour and 1 minute. I do not have the final number of the people who have attended the talk. Unfortunately, this platform allows me to see it only at the end. But I can tell you that I see that we have been watched by 38 countries around the world. I have people from Algeria, Pakistan, China, basically every country in Europe, most of the countries in South America, Uzbekistan, Middle East, so Mexico, United States, Poland. So I want to thank everyone that took the time in a very different moment of their Saturday morning, night, evening, to just talk about vein graft and radial artery. This is awesome, and this is really inspired us as International Society of Coronary Artery Surgery to keep doing what we are trying to do. So not only one meeting per year, the International Coronary Congress, but also try to maintain education, try to talk, try to understand what these trials are about, what we can take as a home message, how should we change the way in which we treat our patients on a daily basis, how can we improve the outcomes of what we do on a daily basis. So thanks everyone who have watched, thanks everyone who have asked questions during the day, and we are waiting for you for the next appointment that will be in February. As you have seen in the agenda, there will be a masterclass in which both Dr. David Taggart and Dr. John Pascas will be attending for off-pump. And in the month of February, our next talk will be coronary artery bypass grafting in women, implication, where to do, graft choices, small conduit, how to handle, how to manage, and outcomes. And we will have a full panel of only female presenting, so we will just disappearing from here, and we want only female be on top of the audience. And I want to thank a lot Dr. Goldman and Dr. Chatoulis for being here, and Dr. Stephen Frames to take the time, and of course, Dr. David Taggart and Dr. John Pascas for moderating and being part of it. Again, thanks everyone for joining, and we hope you have enjoyed as much as we did the session today.
And just before you go, to say to the audience a very big thank you, not only to our speakers today, but to Dr. Gianluca Torregrossa, who has organized these meetings relentlessly, and without him, this wouldn't have happened today. So, Gianluca, big thanks to you as well.
Thank you so much. Really, thank you. I enjoyed a lot.
Thank you. Excellent.
Thank you so much. I'm ending the broadcast for everybody. Stays on board. And this is